What's up, Ninja Nerds? In this video today, we're going to be talking about ulcerative colitis. Before we get started, if you guys want to follow along with some awesome notes, some illustrations, go down in the description box below. We'll have a link to our website where you guys can go ahead and check those things out. Also, if you guys benefit from this video, you like it, it helps you, you have some fun, please continue to support us. And the best way you can do that is by hitting that like button, commenting down in the comment section, and most importantly, subscribing. All right, Ninja Nerds, so also before we get started in this video, I want to tell you guys we've teamed up again with Chegg. Chegg is this online service that provides multiple different resources that can cover anywhere from your undergraduate studies to your graduate studies. There's so many things to offer on Chegg. Let's take a look and see what they have to offer on their actual website. All right, Ninja Nerds, so what I want you guys to do again is go down in the description box below and click on the link, which is going to take you to the Chegg website. It looks kind of like this whenever you click on that. And what's really cool is if you guys do it through this link, it'll give you guys a coupon code, $5 off for your first month of Chegg Study Pack. When you guys click on this, it'll take you to a particular page on their website that'll look a little bit like this. And what I want you guys to do is to see some of the cool features that this website offers. So what I like is click on Study Tools. And you know, here at Ninja Nerd, whenever we're doing any kind of video, we're working on our notes or illustrations, especially like COVID videos, we need to make sure that all of our citations are present so that everything that we present is evidence-based. And if you wanted to have something like that, let's say that you clicked on that Create Citation tab, it'll take you to this really cool citation generator. And you can utilize this in your papers and whatever you're trying to present. And let's say that you pick a website. For example, let's pick something like ninjanerd.org. And if we click on that, it'll take a nice search here for you. And here we have our Ninja Nerd Medicine lectures and notes and illustrations. Go ahead and cite that. And if you do that, what's really cool is that the website will tell you, and kind of this starred portion here, that anything that's starred is highly suggested that you fill that in. So filling in the name of the author, the first name, last name, so on and so forth. And once you've kind of gone through all of that process and filled out all the important necessary information, you complete the citation, and it gives you this nice little kind of thing that you can go ahead and copy, paste into your paper, whatever you're utilizing that you need these citations for. And then also you have all the different formats that you need, MLA, APA, whatever it may be. And again, you can go ahead and copy the citation and then paste that into your paper. So again, check out the Chegg website. Make sure you guys go down in the description box below and click on that link. Check out what these guys have to offer. It's really cool. All right, Ninja Nerds, let's get into our video. All right, Ninja Nerds, let's talk about ulcerative colitis. Now, ulcerative colitis is actually kind of a family under the inflammatory bowel diseases. So within inflammatory bowel diseases, there's Crohn's disease, and there's also ulcerative colitis. Now, let's talk a little bit about ulcerative colitis. Now, ulcerative colitis is believed to be an autoimmune disease. Now, there's a lot of different things that come into play with autoimmune diseases. What is the overarching theme that seems to be with ulcerative colitis is that there's some type of like genetic / immune component here that's just dysregulated. Now the question is what is actually dysregulated within the genes? There's actually no specific genes that we've been able to pick out. What there has been maybe an association with is that, okay, what if there are certain types of genes that maybe we have some association with? So you know there's what's called the HLA-B27 gene. There seems to be maybe some type of an association with inflammatory bowel diseases, especially UC, and certain types of HLA-B27 types of conditions. It's like ankylosing spondylitis, reactive arthritis, psoriatic arthritis, things of that nature. So that's one thing. The other thing is that there seems to be a lot of particular immune cells which seem to be going haywire, and particularly this inflammatory bowel disease of UC type. And what we see is there's certain types of lymphocytes that are becoming super activated, if you will. And the ones that we see is the Th2 lymphocytes. So the Th2 lymphocytes seem to be hyperactive. And when they're in this hyperactive state, they release very interesting cytokines that probably never heard of that actually cause damage and dysfunction of the gut barrier. That's one thing. The other thing is we have cytotoxic damage. There's another type of T cell that is also really coming into play here that we've seen, and this is your cytotoxic T cells. They seem to be becoming hyperactive and causing direct destruction to these actual tissue cells within the gut, affecting the gut barrier and causing tons of inflammation and ulcers. The last one here is that we also see particular types of plasma cells that are getting involved here. And these plasma cells are releasing these antibodies that are also kind of perpetuating the inflammatory cycle. And so there's tons of these nasty little antibodies that are produced by plasma cells that also trigger a lot of inflammation within the gut bowel wall, causing necrosis, causing ulcers, causing just inflammation of the bowel wall in general, and tons of complications that we'll discuss. So that seems to be the genetic immune component. We'll explain what all this stuff means here in a little bit, but this is what I really want you to take away from it, is that what's really the immune problem? There's lots of Th2 cells that are hyperactive, lots of cytotoxic T cells that are hyperactive, and lots of plasma cells producing antibodies, very specific ones we'll talk about. All right, so not only does there seem to be this genetic and immune component here, but there also seems to be some type of environmental component. Now, what is this environmental component? Well, to be honest with you, we don't actually know. There's things that we think may be triggers or related to it, but we don't have a complete understanding of it. Some things that maybe be the case here is diet, maybe antibiotics, maybe certain types of infections. But you know what's really interesting? For Crohn's disease, it was thought that smoking was actually harmful. You know what's really interesting in this condition? We're gonna put it here. It's not a trigger, but it actually seems to be somewhat protective. And so for smoking, for Crohn's disease, it actually was potentially perpetuating the inflammatory cycle, worsening the Crohn's disease, one of the environmental agents. But for smoking and UC, it actually is very confusing because you know what? It seems to be protective, and that's so interesting. Telling people to potentially smoke may be a protective factor for ulcerative colitis. So that's one of the things to think about in comparing between Crohn's disease and ulcerative colitis. So we have these two components. We have an environmental component and we have a genetic immune component. How does all of this kind of look with particularly causing inflammation and ulcers and destruction of the bowel wall? Well, what happens, the overall process here is that with these factors, there seems to be some type of issue where the mucin proteins that basically, you know, this blue layer, this is all mucin produced by what kind of cells? You see these cells right here? These are called goblet cells. And the goblet cells are the ones that contain these mucin proteins that they secrete onto this gut wall layer, right? And it kind of forms a barrier, if you will, between the intestinal epithelial cells and the bacteria. Well, what happens in this kind of disease of ulcerative colitis is this barrier, the mucin barrier, becomes affected. And then the intestinal epithelial cells, normally they have like tight junctions between them that are really, really good at being able to maintain a barrier between the lumen and what's underneath the lumen, okay? What's behind actually the intestinal epithelial cells, really. And what happens is in ulcerative colitis, they start having some increasing separation between these epithelial cells. So now they were really, really tight and really preventing things from moving across the epithelial cell layer. But in ulcerative colitis, they have kind of an increased permeability. So not only do they have a kind of a destruction or loss of mucin proteins, which is a part of the barrier, but also they have this increased permeability between the tight junctions of the epithelial cells. So there's two things right there. What thing is it? One is a decrease in the mucin barrier. And the second thing is there is a increased permeability between the epithelial cells. All right. If that happens, then guess what? This bacteria is going to be able to easily move and translocate from the gut lumen into the actual intestinal wall. Now, once this bacteria is in the actual gut wall, it can start causing some problems, especially in ulcerative colitis. So what it does is it interacts with very specific types of cells called antigen-presenting cells. You know what one of the specific ones are that are located here? Well, there's two types. You have the macrophages, and then you have dendritic cells. The macrophages love to just eat up that bacteria, and they undergo a phagocytosis process. So what's going to happen as a result of this? The macrophage, or what other kind of cell? Dendritic cell, will phagocytose the bacteria. When it phagocytoses that bacteria, it processes it and presents a piece of that bacteria on its surface, on this molecule here called an MHC2 complex. So here's going to be a piece of the bacterial antigens that are presented on its surface. Then what happens is, here's what's really cool. This macrophage or dendritic cell will go and present this antigen, this bacterial antigen that crossed over to a T cell. So here we're going to have a T cell. So here's our T cell. Now this is a naive T cell, meaning that it hasn't really decided what it wants to be yet. Does it want to be a Th2 cell, a Th1 cell, a cytotoxic T cell? So he's got many options, right? So he's got a T cell receptor that interacts with this antigen, and then a CD4 protein that interacts with the MHC2 complex. Once these interact, it's like ba-bam! It's electric. And there starts to be these massive types of cytokines that are released. What are the cytokines that get released? Well, the macrophage or the dendritic cell will start pumping out very special types of molecules, such as interleukin 1, interleukin 6, interleukin 12. What's also known as, there's another one here, big one, TNF alpha. So there's a bunch of different cytokines that are released. But the big one that I want you guys to remember that this guy's going to start pumping out is TNF alpha. Okay. Here's the interesting thing. This interleukin 12 is one of them, but there's another cytokine that for some weird reason gets released in ulcerative colitis and not really in Crohn's. And this cytokine is called interleukin 4. What interleukin 4 will do is it'll act on this T cell and tell this T cell to differentiate into a very special type of T cell. And this T cell that it differentiates into is called a Th2 cell. Remember I told you that Th2 cells are hyperactive in this disease? And they start releasing cytokines that you probably never heard of before? Guess what they are? Once this Th2 cell becomes activated, it starts releasing what's called interleukin 5 and interleukin 13. All I want you to know is that it releases cytokines, this Th2 cell, that causes an increasing disruption in the epithelial barrier. So it's going to perpetuate this cycle here. It's going to cause more bacteria to translocate across the epithelial cells into this area and perpetuate this inflammatory cycle. Does that make sense? So again, interleukin 4 released by the macrophage tells these naive T cells, we'll put Th0, we don't know what the heck they are, to become Th2 cells who release cytokines that disrupt the epithelial barrier and perpetuate this entire inflammatory cycle. Okay? Bad. What else can happen? The other problem here is that interleukin 12. The interleukin 12 also seems to stimulate some of these T0 cells, some of them, to turn into Th1 cells. Right? So you might get a little bit of Th1 cells. And these Th1 cells, we already know, what do they release? They release particularly like interferon gamma and tumor necrotic factor alpha. And these obviously are going to perpetuate your inflammatory cycle. They're going to cause more macrophages to come to the area, more dendritic cells to come to the area, tons of inflammation. But here's where it gets really interesting. There's some cytokines that are being released that we don't really know how this happens. Seriously, we don't know how. But some of these T0 cells can get converted into a very interesting type of cell. And this is a cytotoxic T cell. Remember I told you that this is one of the ones that really starts amping up? So the two ones that are amping up here is you're going to have a lot of this one, the Th2 cells, secreting these cytokines, interrupting this epithelial barrier. It's going to stimulate this process. Then you have a little bit of these cells, not too many, so we'll put a down arrow, not too many of these, but lots of these. It's through some specific cytokines, we don't know how. But these cytotoxic T cells become activated. What do cytotoxic T cells do? They kill. So what it's going to start doing is these cytotoxic T cells, when they're activated, they're going to start destroying or killing cells within the gut wall. And that includes maybe some of our own immune system cells, that includes our epithelial cells, that includes all of these different types of cells, maybe some of the bacteria as well, but it's going to start causing killing of multiple different cells. That killing of cells is going to cause tissue destruction. And that tissue destruction that you're going to start experiencing here within that gut bowel or the bowel wall is going to start becoming problematic, and that is going to lead to those ulcers, that's going to lead to the inflammation, the lesions that you'll see within the bowel wall. So don't forget this one, don't forget this one. The only other thing that I kind of really want you guys to remember here is what are all these other cytokines doing, right? So we talked about how the macrophage releases cytokines, activates Th2 cells. The cytokines activates Th1 cells. Big one activates cytotoxic T cells. The other thing that I want you to know is that these cytokines can also do other nasty things. So some of these cytokines, especially the TNF alpha, the interleukin 1, the interleukin 6, they can kind of spread and do a couple things. They can get into the bloodstream, right? Or they can act on this vessel wall. So here's our beautiful little vessel, all right? And the vessel has these endothelial cells. Now, what happens is these chemicals can act on the endothelial cells, stimulate these endothelial cells. And you know what happens is when endothelial cells are stimulated, they also secrete cytokines. But one of the things that they do is they start expressing these very interesting little molecules on their surface. You know what these are called? These are called cell adhesion molecules. So they increase the expression of what's called cell adhesion molecules. So increased expression of cell adhesion molecules occurs here. After we express these, these chemicals tell white blood cells that are floating through this area. What kind of white blood cells? Maybe some more macrophages. Maybe it'll tell some neutrophils that are kind of running through this area here to come to the area. It might even tell what else? Lymphocytes, probably one of the big ones here, to come to this area. How do these cell adhesion molecules interact with these white blood cells? I'm glad you asked. The white blood cells, let's do this in pink, have very special proteins on their surface that interacts with these cell adhesion molecules. What are these proteins here called? They're called integrins. What are these proteins called, these pink proteins? They're called integrins. And there's very specific points of me talking about all this stuff because there's drugs that work on these particular types of pathways. Okay? Now, when we talk about all of these types of mechanisms here, once the white blood cells have their integrins interact with the cell adhesion molecules, the whole process is that these white blood cells will come into the area. We'll have more macrophages who will phagocytose more antigens, interact with the T cells, increase this pathway of Th2 cells, cytotoxic T cells, a little bit of Th1 cells. We'll pull in neutrophils. What's the problem with neutrophils? If neutrophils get pulled into the area, they release lots of reactive oxygen species. They release a lot of what's called proteases, and these things cause just natural destruction of nearby tissues. And by default, that includes the bowel wall. And then the last thing is, we'll pull in more lymphocytes. And as you pull in more lymphocytes, you're going to have more of these types of lymphocytes like T cells and B cells coming in, interacting with the macrophages, becoming Th2 cells, cytotoxic T cells, and just perpetuating this entire cycle. Here's the last thing that I want you guys to remember. Through all of these cytokines that are being released, and again, we don't know how, it may be related to the cytokines that are released by the Th2 cells. That's the only thing that may be a little bit different here, is that some kind of cytokines that are being released in this kind of massive inflammatory cycle activates very, very special cells. Let's do these cells in this bluish color here. So all these cytokines are being released. This is the last thing that I want you guys to remember. From these cytokines that are being released, you also have these cells nearby, and these are called your plasma cells. So you have B cells, and what happens is maybe some of these cytokines that are being released are activating the B cells and converting the B cells into plasma cells. Okay? So this is our plasma cell. There's tons and tons of cytokines that are being released. It's not far-fetched to think that some of them could activate these B cells, turn them into plasma cells. When these plasma cells are activated, they start secreting very important types of antibodies. And these antibodies will start destroying, inadvertently, some of the proteins in the tissues, but very, very specifically the neutrophils. You know, there's a protein in the neutrophil that actually kind of resembles some of maybe the antigens from these microbes or from these pathogens or from the intestinal epithelial tissue, anything like that. And so what happens is there's what's called this process of molecular mimicry, where you produce antibodies that are supposed to be against this antigen, but one of those antigens looks just like one of the antigens or proteins in the neutrophil. And so these antibodies destroy some of the neutrophils. And again, this is just going to perpetuate that inflammatory cycle. There's a very special name for these antibodies. They're called cytoplasmic, anti-neutrophilic cytoplasmic antibodies. Kind of redundant, right? But these are called p-ANCAs. And so there is an increase in this within ulcerative colitis and compared to Crohn's disease. So what are the big things that I really want you guys to take away? Let's mark it with an orange marker, the big things to take away here. One is there's an increase in Th2 cells, which release cytokines that disrupt the epithelial barrier. Second thing here is there's lots of cytotoxic T cells that promote direct killing of the particular bacteria, but inadvertently parts of the actual intestinal epithelial cells. And there is plasma cells that are increased in this process that release lots of antibodies. These antibodies are supposed to be targeted against the antigen on the bacteria, but undesirably, some of these antibodies may be produced against the bacteria, but inadvertently attack the neutrophils, and these are called pericytoplasmic anti-neutrophilic cytoplasmic antibodies. And these are the big things that I really need you to remember. And last but not least, don't forget all of the cytokines that are being released that are causing not just inflammation to pull more immune system cells into the area via this process, but the last thing is that all of these cytokines that are being released, right? All of the cytokines that are being released, which ones? Like interleukin 1, interleukin 6, TNF alpha. All of these that are being released, not only do they have an effect locally on the GI wall, or the GI tract, but they also can distribute into the systemic circulation and cause problematic issues throughout the body. What does this look like? Let's talk about that now. All right, so let's talk about some of the actual symptoms or clinical manifestations that you can see with ulcerative colitis. We obviously understand that there's going to be a lot of inflammation within kind of the GI tract wall by a lot of these T cells and plasma cells. So how does this look? Well, obviously there's going to be inflammation of that bowel wall within the GI tract, but what part of the GI tract is most commonly effective is, I guess, the good question to ask. And really, ulcerative colitis really kind of obeys, particularly staying within the large intestine. That's really where it likes to kind of stay. But you know where it commonly kind of originates? It commonly originates near kind of the rectal area. So let's say it starts here in the rectum. What is that called? So it may start off as just what's called proctitis. Okay, proctitis. So that's just an inflammation of the rectum. And you know what's interesting is that from that proctitis, it can extend and maybe start causing some inflammation of the sigmoid colon. So now we have this sigmoid colon being involved. And this is called proctosigmoiditis. Okay, so you have the involvement of the rectum and you have the involvement of the sigmoid colon here. Now, what if it continues to extend? So now it extends all the way up until the splenic flexure. So now it's up here to the splenic flexure. Well, now we call this distal colitis. We call this distal colitis. Here's the most interesting part. What if this continues and continues to cause inflammation that spreads and spreads and spreads and spreads all the way throughout the entire rest of the colon? This is called pancolitis. Pancolitis. So this is how we can actually see patients developing ulcerative colitis. They may start off with proctitis. My question for you is, how does proctitis present? If you have inflammation in your rectum, your booty hole, what's that going to present with? You'll have rectal pain. But you know when the rectal pain is actually present? Particularly during the defecation process. What is that called when you have rectal pain that occurs during the actual defecation process? That's called tenesmus. So they may also have signs of tenesmus. The other thing is, where's it most commonly going to take place? A lot of this inflammation. Usually, it's more likely that they have just left side colon problems, specifically starting with proctitis and proctosigmoiditis. Where is that located in the quadrants of the abdomen? Would you find it in the left lower, the left upper, right lower? You're going to see more of the sigmoid and rectal involvement on that left lower quadrant. And so usually, the presentation in this kind of thing is they may present with, most commonly, left lower quadrant pain. And again, don't forget about that, is that if they have pain near the rectum, that usually is worse whenever they're having defecation. What is that called? Tenesmus. Okay, so we have kind of how this will occur. Now there's a really important pattern of this that you need to know in comparison to someone with Crohn's disease, is that usually it starts here in the rectum and then it continuously ascends throughout the rest of the large intestine until it gets to the cecum. It does not pass that and get into the small intestine or ileum. It usually obeys that line and stops there at the large intestine, right at the cecum. Okay? So there's definitely this ascending continuous inflammatory process in UC. Now that's one thing. Now, if we look at it a little bit deeper, particularly it's only involving the large intestine, what's another big difference? You don't see malabsorptive syndromes with this. You'll primarily see only large intestine involvement. So the large intestine is obviously involved in reabsorbing water. if you've destroyed the epithelial tissue here, right? So someone who has ulcerative colitis, they're going to have lesions here, they're going to have ulcers, they're going to have damaged epithelial cells that lose the ability to draw water across the GI tract. So if you can't reabsorb water across the GI tract, you lose the ability to do that because these epithelial cells are damaged. What happens? Well, then you lose water into the poo-poo, right? And that can obviously lead to kind of a low volume kind of state, right? So there's definitely decreased water absorption. So if there's decreased water absorption, this can maybe lead to a slightly dehydrated state, right? Simple thing. The other thing is that what's really interesting, because in the large colon, there's so many more ulcers and they're continuous, it seems to really hit some of those blood vessels. And when it hits those blood vessels, it actually can cause bleeding, pretty decent bleeding, especially near the rectum or sigmoid colon. And so you can actually get blood that enters into what? Into the stool, right? So you're going to have blood that enters into the stool. Now here's another thing that's important. If you're reabsorbing less water across the GI tract, yeah, it can lead to dehydration. But what's another effect? If you have lots of water that's staying within the bowels, what's that going to do to the poo-poo that you're making? That's going to make it more watery. What's that called when you got watery stools? It's diarrhea. So the other fact here is that not only can this water that you're not reabsorbing cause dehydration, but it can also cause diarrhea. Now here's the next thing that's important. Because you're also losing blood in the stool, so blood is also being lost in stool. That is going to cause GI bleeding, right? There's definitely an aspect of a GI bleed. But more importantly, this can cause blood to present within the diarrhea. So what kind of diarrhea may you see in these patients? If you combine these two concepts here together, you obviously get a person with diarrhea that's watery plus blood that's combined in the stool. This is bingo, bango, boom, bloody diarrhea. So this is a big difference in comparison to Crohn's disease. They didn't have bloody diarrhea, they had watery diarrhea. Bloody diarrhea is going to be more consistent in someone with ulcerative colitis. Okay, let's go on to the next aspect here. The next thing here that's really, really important with ulcerative colitis is to understand other complications. So one of the big complications that you can see, especially with the GI tract, is what's called fulminant colitis. So this is whenever the inflammation, the ulcers, the problem with ulcerative colitis involves so much of the large bowel that it's so inflamed that there's such a significant inability to be able to absorb water, to absorb electrolytes, and there's also bleeding. There's more bleeding. So there's definitely going to be this kind of, imagine what we had up here with diarrhea, but worse. So imagine more blood in the stool, and imagine also, in addition to that, more water in the stool, okay? And here's the next thing. Not only do you imagine more water and more diarrhea, imagine it happening more frequently. You know how many times? And in order to really have a diagnosis of fulminant colitis, you have to have greater than or equal to 10 stools. And they're usually bloody diarrhea a day. Okay, that's kind of one of the signs here. And then usually not only is there this kind of sign here, but you may even start seeing signs of potentially the beginning, some small dilation of the bowels, meaning that you're starting to proceed into a very scary condition called toxic megacolon. So that's some of the big things that you want to start thinking about. Is usually these patients have 10 plus stools a day. They're usually bloody diarrhea. Their bowel walls are maybe, the bowel lumen's starting to begin to dilate, getting ready for them to progress into what's called toxic megacolon. But the big thing to take away from this, with the 10 plus stools a day, usually bloody diarrhea, is fulminant colitis. Now, what if they do progress? What if the inflammation becomes so bad that it really starts causing some problematic issues? You know what's really interesting here? Whenever there's so much of this destruction of the tissue wall here, obviously there's tons and tons of inflammation. Well, with this inflammation, what seems to happen is two things. One is, we don't know how, but maybe bacteria, maybe some of the epithelial cells, there's an increase in nitric oxide for some reason. And when you increase the amount of nitric oxide, okay, what does that do to the actual smooth muscle cells? So imagine here is some smooth muscle cells within this bowel wall here. I'll put them kind of like in this red color here. So here's the smooth muscle layer here, and then here's the smooth muscle layer here. What would the nitric oxide do to the smooth muscle cells? It would cause them to relax. If it relaxes, it would cause the bowel wall to dilate, right? And so what would I see as a result of this increase in nitric oxide? I would see bowel dilation. Here's another thing that happens. With this inflammation, not only does it cause an increase in nitric oxide, but you know what else it does? It inhibits the actual nerves of the myenteric plexus. You know there's a plexus that supplies this area here. Let's say that we do it here in this orange color. You know there's nerves that are actually a part of the enteric nervous system, and they supply these muscles of the muscularis externa. These become inhibited because of the inflammation. And from that, if these nerves become inhibited, can they trigger the smooth muscle to contract? No. And so because of that, this causes bowel dilation. And because this bowel becomes so dilated, the walls become super thin, and so you start having this very, very large dilation effect, and the walls become very, very super thin. So now I'm going to have these super thin walls with very large diameter lumens. You know the lumen, if it gets like greater than 6 centimeters, that's one of the signs there. So you may start having a very dilated bowel lumen, or dilated bowel loops, greater than or equal to 6 centimeters, very thin walls. But you know what else you need to have the diagnosis of toxic megacolon? Not only do you need colon dilation, not only do you need some maybe signs of potential diarrhea, but also this really thinning and real significant inflammation starts causing the increased risk of bacteria to seed into the circulation. Because you have an increased risk of like perforation. So sometimes the bacteria can seed into your circulation. And if the bacteria seed into your circulation, what happens to your immune system? They rev up. And so as a response, you may increase your white blood cells, called leukocytosis. You may respond with a significant fever from your white blood cell response, releasing tons of cytokines. But you know what else? You may start seeing signs of hemodynamic instability, such as significant tachycardia, hypotension, altered mental status. These are things to think about. So if they have dilated colon, radiological evidence, right? They have diarrhea, they have a sign of leukocytosis, fever, hemodynamic instability, and the bowel walls are very, very thin, this could be a diagnosis of toxic megacolon. The scary thing with toxic megacolon is the larger and larger and larger the bowel wall is, with the thinner and thinner and thinner, well, the larger the lumen is, and the thinner the actual wall is, there's a high risk of what? There's a high risk of perforation. And so that's the scary thing, is we have a high risk of perf with toxic megacolon. So we really want to be careful with that, okay? All right, so we've talked about diarrhea, we talked about fulminant colitis, we talked about toxic megacolon. What's another problematic issue? Well, the other thing is that they're having these ulcers, right? So you have the ulcers, and then usually someone goes into this period where they have they have a relapse. And just like in any kind of autoimmune disease, you have a period where your immune system flares up, and then you get a lot of inflammation, particularly within the bowel walls. And so they get inflamed, they develop ulcers, they develop these lesions, and then maybe you get them under a good regimen, and they get kind of a remission. So they go into a period where they don't have a lot of this immune system flaring up. During that time period where the immune system isn't really flaring up, you may start having your immune system try to kind of recover and heal up some of these areas of ulcers. And so sometimes it can lead to maybe some fibrosis. But then what happens if your immune system flares up again? Then you develop lesions on top of that. And before you know it, with multiple relapses, and then you have again the remission, relapse, remission, relapse, remission, before you know it, you start developing this significant area of inflammation with fibrosis, and so it just really starts causing a significant narrowing of the actual lumen. So with, again, lots of relapse and remission, if this continuously keeps happening and your immune system is firing and causing damage, and then you're also trying to heal, this increases the risk of stenosis. And that stenosis can cause this narrowing of the bowel wall. What happens if you gotta get poop through that area? You can't get it through that area. So it gets stuck, and everything proximal to that starts dilating. And you start developing abdominal distension, vomiting, nausea. You start having no ability to make bowel movements, right? So you aren't able to poo-poo. And these are problematic issues. And so these strictures definitely increase your risk of what's called bowel obstruction. Okay, and so that is the problematic issue that I really want you guys to think about with strictures. Okay? What's the last thing that I want you guys to remember? Well, again, it's a very simple concept. Anytime you have cells that are replicating, those DNA polymerases, they can easily make a mistake. And if they make a mistake during the proofreading process because you're constantly damaging the tissue and they got to go in and replicate your epithelial cells, there's always a chance of them making a little proofreading mistake. And guess what happens with that replication cycle constantly? You make a proofreading mistake, you lead to a mutation. What happens if you have multiple mutations? Then you can potentially lead to cancer, right? So there's always the risk of this oncogenesis process because of multiple types of replication to heal the damaged epithelial cells that you caused during that relapse. So it's again the same thing. If you have multiple episodes of flares and tons of episodes of maybe, well, primarily lots of flares, really. So the more flares you have, and then you get these time periods of, again, remission, you have an increased risk of you forming mutations. And so this can increase the risk of colorectal cancer. So increased flares and increasing periods of remission, same thing as we talked about before, there's always a chance, increased risk of a mutation. So there's always increased risk of mutation. So anytime you're having lots of replication, there's always a chance for that DNA polymerase enzymes to mess up, make a mistake, cause a proofreading mistake, and increase your risk of causing a mutation leading to cancer, okay? And that covers the GI effects. Now what I want to do is I want to cover the systemic effects of ulcerative colitis. All right, so let's talk about some of the systemic effects of ulcerative colitis, right? So it's crazy. It's a lot of inflammation that's going on within kind of the GI tract. But again, if a lot of those cytokines, the interleukin-1, the interleukin-6, the TNF-alpha, they get out into that systemic circulation and they start spreading around, you get a good enough flare, you can definitely get some systemic involvement, right? You get into the systemic circulation, you can spread it anywhere you want. And so what's the problematic issue with this? Well, generally, you want to think about it. What happens when you have any kind of increase in interleukin-1, TNF-alpha, interleukin-6? We know that they definitely act on the hypothalamus, right? And when you act on the hypothalamus, it increases that production of prostaglandin E2. And what does that do? That resets your body's thermostat and tries to jack up your body temperature. And what is that called whenever you increase your body temperature? It's going to lead to fever. And so one of the signs here is there may be some general symptoms such as fever. And whenever you have a fever, you just feel like crap, right? You just feel just generalized discomfort. And so sometimes you can have malaise as well. So there can be some fever, there can be some malaise, but it's just your generalized symptoms. They're non-specific. What is a little bit more interesting is that you get a lot of inflammation. It likes to involve the eye, right? So you know the eye, there's definitely the conjunctiva, and then you have the sclera, right? So you have like if you had your eyelid there, there's a fold there that lines the palpebra, and then it kind of folds back onto the eyeball called the bulbar conjunctiva. Well, there's a whitey part of the eye called the sclera, and then there's just a little layer right over the sclera, which has a lot of blood vessels, called the episclera. For some reason, this inflammatory process loves to just jack up the episclera. And so what does that call whenever you cause inflammation of the episclera? Episcleritis. Right, so that's one thing that we may see. The other thing is not just episcleritis, but it loves to involve the uvea. Now the uvea has two different parts, right? So you have the anterior aspect of the uvea and the posterior aspect of the uvea. The best way to remember is that the anterior uvea pretty much is just the iris. Right? So that little guy that constricts and relaxes and opens up the actual pupil hole. And then the other part is you have like the ciliary body, and you have the choroid and the retina as the posterior part of like the uvea, right? And so generally, in this condition, they love to just rev up the activity of the anterior and posterior uvea. And so you can develop uveitis. And this uveitis is of the anterior flavor and the posterior flavor. But boom, we good. This is actually a really, really important one with the skin. One of them is it causes these kind of like reddish, like nodules that can appear really throughout any part of the extremities. And this is actually called erythema, so obviously red, erythema nodosum. So they're kind of like these like little red nodules that can appear anywhere kind of on the skin, usually more in the extremities. And then the other one that I definitely need you guys to remember, it's really nasty looking, but it's called pyoderma gangrenosum. So pyoderma gangrenosum, this is usually more on those extensor surfaces. It honestly looks like just a nasty infected pus-like lesion, but this is very, very important one to remember in patients with inflammatory bowel disease. Okay, so we got general symptoms like fever, malaise, nonspecific. Then you get the eyeball, don't forget that one, uveitis, episcleritis. Then you get the skin, erythema nodosum, pyoderma gangrenosum. The next one, which is actually really, really important, probably one of the most important ones, is the joint involvement. So they love to involve the joints, right? When you get to the joints, it loves to like cause inflammation of kind of like the vertebral column, right? So it loves to cause inflammation of the vertebral column near like the joints and the bones there, like near the intervertebral disc and the vertebral bodies and things like that. And whenever you cause all this inflammation here, particularly of the vertebral column, we call that spondylitis, right? Spondylitis. So what else does it cause? Besides the spondylitis, it's going to involve the inflammation of the sacroiliac joint. If you jack up that sacroiliac joint, it can cause sacroiliitis. So you can get spondylitis, you can get sacroiliitis, you can develop like some low back pain, right? You can develop some pain within the hip area. And it can also involve inflammation of different peripheral like joints as well. But what I want you to remember that's really important with this bone and joint thing is that this is where we see that HLA-B27 like haplotype mutation present. And so this is a part of a category of like spondyloarthropathies called seronegative spondyloarthropathies. So there's similar diseases that can look just like this. Ankylosing spondylitis, reactive arthritis, also known as Reiter syndrome, or psoriatic arthritis, and even what else? We call it enterohepatic arthritis, IBD arthritis. So it's a part of that category of what's called seronegative spondyloarthropathies, which are HLA-B27 haplotype mutations. Please don't forget that, okay? All right, so we've gotten this down. What are other systemic involvement here? All right, so what is another kind of systemic involvement of ulcerative colitis? Well, you definitely want to remember this next one, right? So this is where you kind of get a little bit of a difference between Crohn's disease and ulcerative colitis. Remember in Crohn's disease we said that you can get what's called primary sclerosing cholangitis. You can definitely get that. Remember we said it's way more common in ulcerative colitis. So the hepatobiliary involvement is you definitely get a lot of this inflammation of the biliary tree. And this includes the extrahepatic, like the common bile duct, a little bit of the cystic duct, common hepatic duct, but as well as like the intrahepatic duct. So all of these like little guys that are branches of the right and left hepatic ducts. All of these can become super inflamed. Now the problem with this is if you get lots of inflammation, it can cause like, fibrosis of these actual biliary trees. And that's where you kind of get this primary sclerosing cholangitis. So we can see this condition called primary sclerosing cholangitis. Now, here's what's interesting. Believe it or not, it's actually what seems to be ulcerative colitis. Definitely there's like 4% of patients who have that develop primary sclerosing cholangitis. What they're actually thinking is that it's actually maybe opposite. People with primary sclerosing cholangitis, most of them have UC. It's not UC that leads to PSC in small populations. Nonetheless, what I want you guys to remember when you're comparing this with Crohn's disease is that usually UC is more commonly associated with primary sclerosing cholangitis. What's the problem with this? The problem with this is that if you cause all this inflammation of the hepatic ducts, you're affecting the biliary drainage. And so you obviously may see like an increase in certain types of biliary enzymes. There may be an increase in alk-Phos. There may be an increase in what's called the GGT enzyme. That's definitely possible. So you always want to check those. Do they have any jaundice? So these are kind of simple things. The problem with all of this inflammation and fibrosis of the hepatic ducts is that it may start affecting the liver. And this may start leading to signs of cirrhosis. And worst case scenario, with lots of inflammation of this biliary system, this is the worst case scenario. Anytime there's chronic inflammation over long periods of time, you increase the risk of cancer. And so there's definitely a high risk of what's called cholangiocarcinoma. Okay, and this is so much more important like whenever you're thinking about this in comparison to Crohn's disease. So the two big things that I really want you to remember is that you see PSC, primary sclerosing cholangitis, more commonly in UC than you do in Crohn's. And because it's this chronic inflammation, there's a higher risk of what? Cholangiocarcinoma. Okay? Good deal. Let's move on. Next part here is the vascular involvement. It's the same thing as we did with Crohn's disease, that whenever you have all this inflammation, right? So you have all of those cytokines that are moving through the circulatory system, right? Which ones? Interleukin 1, interleukin 6, TNF alpha, all these different types of chemokines. These have the ability to increase the procoagulant enzymes. If you increase the activity of your procoagulant enzymes, what's the problem with that? You know what's interesting is not only does it increase the activity of the procoagulant enzymes, it also has been shown to increase the activity of your von Willebrand factor. So if you imagine here, just really simply here, let's imagine here's a small tear within the blood vessel wall, and here's that von Willebrand factor protein. If there's increased expression of this protein, that means more platelets will adhere to this area. So then you're going to get more of these platelet plugs. On top of that, not only will you get more of these platelet plugs, but you're going to have an increase in the procoagulant enzymes. So all those factors, factor 12, yada, 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 those are going to increase. And they're going to increase the formation of thrombin and the fibrin mesh. And so they're going to get an increase in clots, right? So the combination of these two things here, an increase in the procoagulant enzymes and an increase in the von Willebrand factor, increases the risk of clots. And these clots can occur on the venous side, so we call these venous thrombi, which are way more common, but they can also occur on the arterial side. And these are obviously arterial thrombi. But again, please don't forget it's going to be more common that you'll see this on that venous side, like DVTs and PEs. Okay? Beautiful. We got fever, we got episcleritis, uveitis, we got erythema nodosum, pyoderma gangrenosum, spondylitis, sacroiliitis, primary sclerosing cholangitis with increased risk of cholangiocarcinoma, venous arterial thrombi. That's your systemic complications. The last thing that I want to talk about before we start going into the diagnostics is we see a lot of this at the macroscopic level, right? Organ involvement, tissue involvement, particularly. But what if we really broke it down? We looked at how does ulcerative colitis really affect the GI tract wall at a microscopic level. There's an important couple points that you need to know. Let's take a look at this. All right, so let's talk a little bit, really quickly about the microscopic structure of the GI tract wall, the alimentary canal. You know there's a bunch of different layers here, right? So the first one is the epithelial cell, right? With the lamina propria, which is this purple layer, and the muscularis mucosa, which is this tiny little red layer. This makes up the mucosa. Then you have this dense, fibrous, irregular connective tissue layer, right? Which is this blue layer here. This is called the submucosa. And then you have this big layer of muscle, so smooth muscle. This is called your muscularis externa. And then last but not least, you have this pink layer here, which could be serosa, if it's like an intraperitoneal organ, or adventitia, if it's a retroperitoneal organ, right? Simple as that. Now, with ulcerative colitis, guess what? They get lesions that only involve, in Crohn's disease, what did it go to? Crohn's was all the way down. That son of a gun went all the way down to like the serosa adventitia layer. And ulcerative colitis is pretty much down to this point here. So they involve what layers then? They involve particularly the mucosa. They'll hit all of this part, so there'll be an ulceration of that layer. And they also involve the submucosal layer. So that is the involvement there. So what I really want you guys to take away is a difference in microscopic destruction is that in ulcerative colitis, what is the lesion involving? It's primarily only mucosa and submucosa in comparison to transmural with Crohn's disease, which is the whole son of a gun. Okay? So that is a big difference there when you're comparing these two. Okay, the last thing here is another high yield point, especially for your exams. For some reason, you know, like whenever you look at the intestinal epithelium on the microscope, you have these big finger-like projections. They're called villi, right? So these are these little things here, these big like finger-like projections. These are called your villi, your intestinal villi. And then you have like these little divots. And these little divots here are called crypts. What happens in patients with ulcerative colitis, they get destruction of these crypts. okay, when a lot of that inflammation was going on back there. And what really seems to happen, interestingly, is that neutrophils, remember those neutrophils that were getting propagated to the area from the chemotaxis and the cell adhesions and all that stuff like that, they love to just kind of accumulate into this area of the intestinal crypts and form like a pocket of immune system cells and dead tissue cells, kind of all getting encapsulated. What is that called whenever you have the kind of like this encapsulated area of dead tissue and white blood cells and all that? What is that called? An abscess. So we call these crypt abscesses. This is actually a really important thing. So I want you to remember that this is another differentiation factor when you're comparing someone with ulcerative colitis and Crohn's disease. In Crohn's disease, they not only had transmural involvement, but what were those like areas of like a bunch of inflammatory cells like lymphocytes and macrophages and fibroblasts, and they were all kind of accumulating there. What were those called? Non-caseating granulomas. They don't have that in UC. What do they have instead? Crypt abscesses. Don't forget that. Okay, now that we've covered all of this, let's talk about how we go about diagnosing UC. All right, so let's talk a little bit about the diagnosis of ulcerative colitis. Obviously, if we were to quick review, we have a patient who there's a lot of different risk factors, right? Particularly like the diet, maybe a family history. Obviously, a family history is a big one. We didn't talk about that, but having like an Ashkenazi Jewish history is also a big thing to think about. But obviously, there's diet, there's antibiotics, there's infections, there's NSAIDs. Smoking is that protective factor. There's lots of immune system cells that are getting involved. You're getting diarrhea, you're getting that left lower quadrant pain with tenesmus, you're getting bloody diarrhea, increased risk of fulminant colitis, toxic megacolon, strictures, colorectal cancer, fevers, malaise, uveitis, episcleritis, you get erythema nodosum, pyoderma gangrenosum, spondylitis, you can get sacroiliitis, you can get primary sclerosing cholangitis, you can have increased risk of venous and arterial thrombi. All of these things are problematic issues, and if you have any of those patients with those clinical cues, you say, I think they may have ulcerative colitis. What are some things that I could test them for? Well, like I could start off with some easy labs. It's always important to start off with some things that are relevant to their bowels. What could I do? Well, you know, whenever somebody has all of this chronic diarrhea, you may not know that it's chronic. Maybe this is their first relapse of ulcerative colitis, and this may present like an acute episode of diarrhea. One of the biggest things I think you should do anytime anybody has this intense diarrhea is you should always rule out some type of infectious process. So rule out infectious diarrhea. You should always do that. Send off all the stool analysis that are related to certain types of pathogens, okay? That's the first thing you should do, right? The second thing is, obviously with a patient who has this blood loss, you know, if you're having a lot of, you know, leakage of red blood cells, they can obviously have anemia, right? So if you're losing some red blood cells because of the actual ulcerative lesions there, what else could you pick up on a CBC? So a CBC, if you ordered that, it may just show anemia. Maybe it's iron deficiency anemia. Maybe it's kind of a normocytic, normochromic anemia. Usually it's going to be more iron deficiency related. What else could I do? Well, the other thing is, remember when I told you there's lots of inflammation? A lot of those neutrophils, they say, okay, lots of inflammation, baby. I'm releasing all those reactive oxygen species and proteases and trying to control the inflammation. But at the same time, I'm going to release all these other chemicals that can end up in the stool, which is kind of a marker of inflammation. And what are these black chemicals here called? These ones here are very kind of interesting little inflammatory molecules. And these are called fecal calprotectin. This would be positive or elevated, or another one called fecal lactoferrin. Fecal lactoferrin. Okay? So these are some things that you definitely would want to think about. So first thing is get a stool analysis to rule out any kind of infectious diarrhea. Okay? Maybe check some toxins as well. Get a CBC. Look to see if they have any signs of iron deficiency anemia. Check the stool for any kind of inflammatory molecules like fecal calprotectin, fecal lactoferrin. Okay? After you've done that, that's kind of just a quick generalized step. The next thing is, remember I told you that some of these patients have that primary sclerosing cholangitis, a good chunk, and again, we don't know if the relationship is inverse, but nonetheless, not to get bogged down in the details, with your test involvement, if there's inflammation of the biliary tracts, you know that there could be some risk for elevated biliary tract enzymes. So maybe take into consideration checking what's called a GGT and seeing if there's also an increase in the ALK Phos. The GGT is a little bit more specific for the biliary involvement because ALK Phos can be released by other types of tissues as well. So check that. But what else? Remember how we said all those cytokines. What were the big ones? The interleukin 6, interleukin 1, and tumor necrotic factor alpha, or TNF alpha. Remember, these were all released because of that massive kind of cytokine release from the GI tract wall. These act on the liver. All right, there's also the release of other types of molecules. These are not as good as fecal calprotectin and fecal lactoferrin, but they're kind of in the same category. They're just this kind of molecules that are indicative of generalized inflammation. And so this could be an increase in their CRP and an increase in their erythrocyte sedimentation rate, okay? So these are things to look for. So, okay, first thing I want you guys to do again, check out stool analysis, rule out infectious causes, get a CBC for anemia, check for these a little bit more specific bowel wall or GI tract related inflammatory markers, check for systemic involvement of inflammatory markers, look to see if there's any biliary tract involvement. What's the next one? This is where you want to hit it home. It's not always a super intense test. The specificity is decent, but the sensitivity is not great. The plasma cells, remember? They release a very, very special type of molecule that's really only present in UC, not in Crohn's disease. What are these antibodies called? Remember we said that they're what's called pericytoplasmic, anti-neutrophilic cytoplasmic antibodies. That super weird, redundant type of name. These are positive only in ulcerative colitis. They're positive in ulcerative colitis, and in Crohn's disease, they are negative. They're not there. It's a big, big thing to remember. Okay, so we got that done. Now, after we've gone through, we've done a couple basic labs, we've kind of gone through their history, their physical exam, we go and we consider, let's do a colonoscopy. Why do I want to do a colonoscopy? Well, the colonoscopy can give me a good look at the colon, make sure that I rule out any kind of other odd things that may be going on. Do they have any like cancer? Obviously, is there any other kind of obvious cause that maybe is not elucidated off their history, their physical exam, and some of their lab findings? Also, it's good at being able to differentiate. Is this more UC? Is this more Crohn's disease? So that's a kind of a decent thing there. And when you do a colonoscopy for someone particularly with ulcerative colitis, what is the big, big difference? Remember we said that there was called skip lesions and cobblestone lesions in patients with Crohn's. In ulcerative colitis, there's what's called this continuous, this is like, honestly, this is pretty much it. Continuous ulcerative lesions. And they are occurring where? Usually starting from the rectum, involving the sigmoid, involving the descending colon, the transverse colon, and then maybe even to the ascending colon. It's this constant ascending continuous inflammation and ulcerative lesions that are ascending continuously. That's really it. And then you can take and do the biopsy. And then if you biopsy, what would that show you? That would show you those microscopic features, which would be mucosa. We're just going to do mucosa, and submucosa is the only part of the lesion that's involved. And what were the other things that we saw in those little crypts? Crypt abscesses. Okay. Simple as that, nothing crazy, right? We're just looking for continuous, this is the big word, continuous ulcerative lesions. There's no skip lesions, there's no cobblestone lesions. There's ulcerative lesions, and they're only involving the mucosa, submucosa, and there's some crypt abscesses. Boom, done. A contraindication that you do want to be careful of with doing a colonoscopy and biopsy in a patient with ulcerative colitis is what if they do have fulminant colitis? What if they do have a risk of toxic megacolon? For the love of goodness, do not do that, because you have a high risk of perforation, okay? So if a patient is has ulcerative colitis and they have a really bad flare-up to the point of fulminant colitis or to the point of toxic megacolon, do not do a colonoscopy and biopsy. There's a high risk of perforation. That's the only kind of contraindication in that one. Now the next thing you could do is if you don't get a colonoscopy and biopsy, or you're kind of like unsure, you've done some of these labs and you're like, man, I don't know what the heck is going on. I'm gonna get an abdominal x-ray. You can never go wrong with an abdominal x-ray. Abdominal x-rays are really good because it can pick up a very significant complication that we talked about. What is that complication whenever you check the bowel wall and you check the bowel lumen and it's greater than or equal to 6 centimeters? They also have a combination of a high white count, they have fevers, they have an increased heart rate, they have a low blood pressure, and maybe they even have some significant abdominal pain. What is this concerning for? A toxic megacolon. All of these things are concerning for a toxic megacolon. And again, this right here is a very important thing to be able to remember, okay? So abdominal x-ray is a good test. It's not going to diagnose ulcerative colitis, but what it can tell you is there any concerning findings, particularly for toxic megacolon, which seems to be the highest mortality complication associated with UC. What else could we do? Here's another big buzzword term that you don't want to forget. We don't do this study that often, again, because barium enemas, if a patient does have toxic megacolon, they have fulminant colitis, they have really bad kind of inflammation, you do a barium enema, there's also risk of perforation. But if you did this study where you basically stick a thing up their butt and you're squirting up this kind of contrast study, you're squirting up contrast, what that's going to do is that contrast is going to light up the intestinal lumen. And remember, in patients with Crohn's disease that showed a string sign, they took it orally. They didn't take it they didn't get it up their anus. You guys know where I was going to go with that. But they actually get the particular oral contrast, and it shows what's called a string sign, a narrow strictured area. And patients who are getting a barium enema who have ulcerative colitis, it's weird because it shows their actual, it looks like a lead pipe, honestly. Their bowel walls or their GI tract, their large intestine, looks what's called a lead pipe. And the reason why is you obviously are seeing some dilation of the bowel wall. So there is some dilation. But what's important here is not just the dilation, but also what are these things called here that I try to represent with the little divots? These things here are called haustra. In patients with ulcerative colitis, they lose their haustra. And it becomes a little bit more of just literally a straight pipe without any kind of divots. And that is called the loss of haustra. And again, all of the loss of the haustra in combination with the dilation is indicative of what's called the lead pipe sign. All right, so let's talk about the treatment of ulcerative colitis. Now, it's important that we understand which medications we're giving, obviously, but let's understand why the heck we're giving these medications. Where do they work on? We spend so much time in that whole immune pathway over there. There's a reason for that. And the reason why is we have drugs that are particularly targeting specific aspects of that immunological pathway. So the first one that I want you guys to think about is whenever there's obviously all this inflammation and tissue destruction going on, anytime there's tissue destruction, some of the phospholipids within the cell membrane get broken down. And they get broken down into what's called arachidonic acid, not Alcoholics Anonymous. They get broken down into this molecule which gets acted on. There's a very special enzyme called cyclooxygenase. And this cyclooxygenase stimulates the conversion of arachidonic acid into different types of inflammatory molecules called prostaglandins and leukotrienes. And these bad boys really jack up the inflammatory cycle, perpetuate it, and worsen all the scenarios, right? They cause macrophages to become activated, they start releasing cytokines, they tell T cells to come to the area, they cause more neutrophils to come to the area. It just causes all this problematic issues. So we have a drug that can literally work locally within the GI tract, inhibit that enzyme, and kind of reduce this inflammatory cycle. What is the name of that drug? That drug is called sulfasalazine. So it's called sulfasalazine. Now sulfasalazine, when it actually gets taken into the actual GI tract, it gets broken down into a molecule called 5-ASA. And that 5-ASA, what it's actually doing is it's inhibiting the cyclooxygenase enzyme. So 5-ASA inhibits cyclooxygenase and decreases the prostaglandins leukotrienes and decreases the inflammatory cycle. Pretty straightforward, right? So sulfasalazine, you can actually take this orally, or you can take this as a suppository, so it can be done rectally, or as an enema. Okay, so that's one of the nice things. And the reason why you could actually do it rectally in comparison to Crohn's disease, you couldn't really do that, is because in ulcerative colitis, they pretty much always involve the rectum. the sigmoid colon. Those are most likely the most common areas. So if you put a suppository or you do an enema up to that area, it's going to work locally in that vicinity. So that's kind of the cool thing about it. Now this is really more in kind of the mild diseases. It's more the mild kind of cases that you would use sulfasalazine. Okay, so that's one thing that we could do. The next thing is, not only is there this pathway here, but you know there's also other particular molecules that our macrophages are releasing. They're also releasing all those interleukins, right? Interleukin 1, interleukin 6, and then the problematic guy that we hate, which is that TNF alpha. This is the really scary one, right? All of these cytokines are bad news, right? Because they're going to activate other T cells, they're going to activate neutrophils, they're going to cause this kind of chemotactic process, all of those things. What if we had drugs that could specifically target kind of this generalized inflammatory cycle? Because we know that all of these are also going to do the same thing. They're going to work to jack up your inflammation and all of those inflammatory cells that come along with it, perpetuating the cycle of UC. What if we had drugs that can inhibit the cyclooxygenase pathway, could inhibit some of these cytokines, it could inhibit some of the immune system cells and just really reduce the inflammation? Well, guess what, my friends? We do. And these are called corticosteroids. Corticosteroids. And there's a bunch of these different types, right? So you could use things like budesonide. You could use, so budesonide is generally kind of like your first line. You try this one first. And then if this one doesn't work, then the next one that you'll go with is maybe kind of like a systemic one. A little bit more systemic in the sense that you take these PO or IV, and they're a little bit more potent than budesonide. So this would be things like if you take PO, this would be what's called prednisone. And if you have a terrible, terrible flare-up and it's a bad idea to take PO, then you can do IV. And this is what's called methylprednisolone. So these are really good for like your flares. So an acute flare, or like anywhere, honestly, from mild to severe cases. So generally, this is kind of an all-around, all-inclusive kind of drug. Anywhere from mild, generally you try to save it for the more moderate, but mild all the way to severe. This is a pretty good drug, and it's really good for the acute flares to try to put you into a remission. It's trying to generate or induce remission. It's not good for maintaining remission. It's good for trying to get you out of that flare, really shut down your immune system, calm it down, so that you can start going into a period of recovery. But it's not good at maintaining that recovery because corticosteroids are really immunosuppressive. We don't want to be on those for a long period of time. So corticosteroids, you start off with budesonide more for the mild cases. And as it starts to get, so let's put here mild, as it starts to progress, get to the more moderate to severe cases, then you start getting into more your systemic involvement. Prednisone, methylprednisolone. Usually these are for acute flare, shutting down the flare, and then helping to induce remission and use other medications to maintain that remissive state. Okay, beautiful. What are the other things that we could do? Okay, you know that TNF alpha, it is a son of a gun, right? So this TNF alpha, there's other cytokines that we release, but TNF alpha seems to be a problematic one. There's also other cytokines, interleukin 12, interleukin 23. Interleukin 12 and interleukin 23 don't seem to be that much involved in UC in comparison to Crohn's disease. Remember in Crohn's we had the interleukin 12 and 23 inhibitors, ustekinumab? We don't really use that too much in ulcerative colitis because there's not really a lot of those cytokines that are involved. So TNF alpha seems to be a really son of a gun here and really try to induce a lot of problems. But there is other cytokines that are being released. Some of these cytokines that were inducing the inflammatory process. Obviously, we could give steroids to lower these cytokines because, you know, corticosteroids work to inhibit macrophages and inhibit or reduce all of these cytokines. That's how corticosteroids work, right? They reduce your TNF alpha, reduce your interleukins, reduce the activity of immune system cells, reduce the inflammation, reduce the chemotaxis and migration of white blood cells to the area. So all of that stuff would be happening here. We also have drugs that can work particularly on these proteins that are on the white blood cells. Remember these pink proteins that we talked about here? It works right there, and it interacts with these what's called CAMs. What were these pink molecules here called? These pink molecules were called integrins. And it's annoying, but they're specifically called alpha-4 beta-7 integrins. We have drugs that not only can block the TNF alpha, and we have drugs that can actually block the integrins. what is the benefit of that? And these are your biologic. These are the really more potent ones. We have drugs that can specifically work to inhibit the TNF alpha antibodies that can block the TNF alpha, which if you block TNF alpha, you reduce inflammation significantly. And also remember that TNF alpha was one of those ones that tried to trigger the cell adhesion molecules and cause the integrins to become activated. We have other drugs that can specifically target those integrins. These are our biologics. We'll come back to the third one here in a second. But these are our biologics. So the ones that we can use to be able to target here, we can use what's called TNF alpha inhibitors first. So this is usually a little bit more in the severe cases. The most common one is what's called infliximab. And these are generally more for like the moderate to like severe cases. And really, these ones here are good at being able to somewhat induce remission and maintain remission. The other one here is related to the antibodies that attack these alpha-4 beta-7 integrins. Why would that work? Well, if you inhibit TNF alpha, you reduce inflammation, you reduce the chemotaxis, all that inflammatory cycle. But if you have antibodies that block the alpha-4 beta-7 integrins, can these white blood cells get into the area of the gut wall and perpetuate the inflammatory cycle? No. So if I block them from being able to get out of the bloodstream into the gut wall, I block the inflammatory cycle that they're going to perpetuate. So I can also give another set of drugs. And this set of drugs is called your alpha-4 beta-7 integrin antibodies, okay? And there's really one drug that works against this. And this drug is called vedolizumab. And this is really for more of those refractory cases. So it's usually refractory to TNF alpha inhibitors. So if you've taken a TNF alpha inhibitor, you don't respond to it, you don't improve with it, then you try the alpha-4 beta-7 integrin antibodies like vedolizumab, okay? So we've worked on this pathway. The last pathway that I want to make sense of, it's just only wanted to come into it last because it's right over here, is we can actually utilize particular drugs to really just decrease the activity or decrease the nucleotide synthesis, decrease a lot of the actual different types of cytokine secretion, decrease a lot of the transcription processes. We can really just decrease the number of T cells and their activity. Whether that be by inhibiting the nucleotide synthesis, right, purine, pyrimidine synthesis, whether that be inhibiting the RAC1 enzyme, which inhibits the release of what type of cytokines, interleukin 1, interleukin 6, tumor necrotic factor alpha, all of those things. So if we utilize those kinds of drugs, we have two different drugs that we can actually prescribe here. And again, these are a part of your DMARDs. And this is specifically what's called methotrexate. So methotrexate is actually one of those. And what methotrexate does is it actually inhibits the purine and pyrimidine synthesis, which is needed to be able to incorporate it for DNA replication. So if you can't replicate your actual DNA, these T cells can't replicate and they can't perpetuate the inflammatory cycle. And the other one is azathioprine, also known as 6-mercaptopurine. These also inhibit that RAC1 enzyme, and the RAC1 enzyme is responsible for the interleukin 1, interleukin 6, TNF alpha release, and it also induces apoptosis of the T cells, reducing the number of T cells. These drugs are good for retaining remission. So whenever you have someone with an acute flare of ulcerative colitis, you'll start them off with corticosteroids, or if it's really, really bad, you can also do biologics. The nice benefit of doing that is if you did corticosteroids, you should transition them into something like a DMARD to maintain their remission, like methotrexate, azathioprine, or 6-mercaptopurine. Now, if you start with biologic, the nice thing about that one is that it induces remission, and then you can also use it to retain or maintain remission. Really, sulfasalazine should only be used in those very, very mild cases whenever they have a true contraindication to corticosteroids. Okay, that's kind of the benefit of those. And they're also able to be produced kind of rectally or localized within the area. Now, we've covered all of this stuff. We've covered the medications, the medical therapy that we've tried to optimize. Right, start off with 5-ASA or sulfasalazine. Corticosteroids is a better option for the more kind of like moderate, you can go mild, but moderate to severe cases. From there, if that's not working, again, you can consider biologics. Biologics can initiate a remission and maintain it. But if you want something that's just going to work on maintaining remission because it takes a long time to work, azathioprine and 6-mercaptopurine is something that you can incorporate in after you've helped to initiate their remission. Okay? There's another drug in there that you guys can remember called cyclosporin, but we're not going to go over that as well. All right, so what's the last kind of options for treating ulcerative colitis? We went through the medical therapy, right? Sulfasalazine, corticosteroids, your DMARDs like methotrexate, azathioprine, 6-mercaptopurine, and your biologics like TNF-alpha inhibitors or the vedolizumab. Now, generally, if a patient has they're refractory to all these options, right? You've tried all these medications, you've gone through the regimens, you've tried to titrate, and they're not responding to it. Sometimes the best option is a surgical option. And so you can do what's called a proctocolectomy and what's called a ilioanal pouch. So basically, you're taking all of the disease segments. So let's say that you're removing parts of the rectum, you're cutting here. Let's say that you only have this disease portion here. You may cut, depending upon how involved it is, you may cut near the actual rectum and cut a part of the colon, and maybe you can reroute this, maybe to a colostomy. Maybe you have to make an ilioanal pouch depending upon how much part of the colon you take out. I don't want you guys to get too lost, but you could do a proctocolectomy, and depending upon how much is involved, you may have to do an ilioanal pouch if you've involved a good chunk of the large intestine. Either way, you can cut out the disease segment. And this is what's interesting. With ulcerative colitis, it's curative. Because if you cut out, because you know in Crohn's disease, it's really difficult to cut out all of these different portions. Remember in Crohn's disease, it's skip lesions. So then we have a lesion here, a lesion here, a lesion here, a lesion here, and all the other parts in between are normal. Me cutting that out, that would be disastrous. Plus, it can involve not just the large intestine, but the small intestine. It's literally impossible to be able to stop that or make that curative. Remember, with ulcerative colitis, it starts and then ascends continuously. It's continuous. So if I cut from the portion where it began to the portion where it stopped, I can literally cure the ulcerative colitis and put them into a period of remission. So usually this type of procedure is whenever you have a severe case of ulcerative colitis that they've just been refractory to medical therapy. It's a simple thing, and it can be curative. That's a big thing to take away from this in comparison to Crohn's disease, okay? The big thing to think about is what about that complication I told you, that scary, scary complication called toxic megacolon. In toxic megacolon, they are at high risk of perforation, right? High risk of perforation. And they're also at high risk of like severe infections. Remember, if it's really, really thin, there's a lot of ulcerations, it's an easy opportunity for bacteria to seed right into the circulation. And it can produce a very increased risk of septic state. So there's definitely an increased risk of a septic state. How do I treat the bacterial infection that can come from a septic state? IV antibiotics. And then I need to really, really reduce the inflammation here because this is a lot of an inflammatory bowel disease relationship. So to reduce a lot of that inflammation that's coming from this ulcerative colitis, what can I give to really shut down the inflammation? What did I tell you was a really good drug that really helped to shut down the inflammation, induce remission, but just it inhibits so many different types of immune and cytokine pathways? Corticosteroids. So also doing IV steroids. Now, you obviously do all the other things because in this patient, what would happen? If you have so much toxic megacolon, right, what's happening here? You can develop a bowel obstructive pattern proximal to it. So you can obviously develop nausea, vomiting, inability to be able to pass fecal contents potentially. You may have diarrhea initially, but then afterwards there may be an inability to move contents forward. And so they can develop constipation or inability to make stool. They can develop nausea, vomiting, and some severe abdominal distension and abdominal pain. So with that situation, you might have to do IV fluids, make them MPO, put an NG tube to decompress all of the bowels proximal to the large intestine, all of that stuff. But here's the thing, within the 24, 48 hours, if they don't respond to the IV antibiotics, the IV steroids, and the supportive measures, the best thing to do is a colectomy. So this would be kind of the plus or minus if they failed the conservative measures of IV antibiotics, IV steroids, supportive measures like IV fluids, MPO, NG tube, all that good stuff. You may have to cut out the actual diseased or dilated segment of that megacolon. And that's an unfortunate thing, but that can be something that you can see with ulcerative colitis. All right, last but not least, there is that high risk of what's called colorectal cancer. Because of that constant replication, healing, fibrosis, replication, healing, fibrosis, it's a constant perpetuative cycle. And so that increases the risk of forming a mass. And so whenever someone is diagnosed with UC, they should get a colonoscopy and biopsy 8 years after their diagnosis. And then depending upon the findings of that, they may have to get it every 1 to 3 years later, right? So Q means every 1 to 3 years later, but again, it depends upon the findings of that colonoscopy. So that's the next thing that you have to remember is you have to have very good surveillance of colorectal cancer for a patient with UC and Crohn's disease. UC actually has a higher incidence. So if you're comparing UC in comparison to Crohn's disease, it's much higher risk of colorectal cancer and UC in comparison to Crohn's disease. Why? Because UC involves more of the colon than Crohn's disease can involve anywhere along the GI tract. Okay, so that's a big thing to think about, and I hope that made sense. That covers our video on particularly ulcerative colitis. I hope it made sense. I hope that you guys enjoyed it. As always, until next time.